Diagnostic procedures. Okay, we have a three diagnostic procedure testing. One is your chorionic villous sampling, another one is your amniocentesis, another is the fetal blood sampling or cordocentessis. Everybody is know the time period when you'll start doing chorionic villous sampling is 10 to 13 weeks of gestational age, and the procedure related loss rate is 0.22%, and you have to use a 20 gauge needles. Then in the amniocentesis the period of gestation is at 15 to 20 weeks. Okay, then procedure related loss rate is 0.1 to 0.3%, and you have to use a 22 gauge needles, and the fetal blood sampling has to be done between cordocentessis 20 to 24 weeks. Procedure related loss rate is 1.3%, and you have to use a 20 to 22 gauge needles. Okay, how you will proceed all these things. Okay, how you will proceed. So basically the fetal, if you get a fetal structural abnormality, so our first line, if you have to know the concept is chromosomal microarray. If you is the first line for those having a structural defect in the heart or kidney or any other organs. So basically the first line investigations is chromosomal microarray is the first line for structural abnormality, and fees is the in situ hybridations. Fluorescent in situ hybridation is the rapid diagnosis of common aneuploidy. If you get a rapid diagnosis, then you go for a FIS. And the karyotypings is identify the large chromosomal changes. Okay, and nowadays what happened, because of cell-free DNA screening, that NIPT screening, that there will be a declining the amniocentesis. So basically if you see this flowchart from Williams 26th editions, how they are written. If you have a structural abnormality, then you perform a CMA, chromosomal microarray, prefer over karyotypings. And if there is no structural abnormality, you can consider chromosomal microarray if high risk, detect 1% additional cases. But suspected, if you suspect specific aneuploidy, that is trisomy 21, 18, 13, then you go for a FIS for rapid detections. For aneuploidy screening, rapid detections, FIS will better. If you need further genetic testing, then you go for a perform a karyotyping to detect aneuploidy, polyploidy, balance rearrangement. So basically these tables is very important for your exam point of view. So amniocentesis, I told the timing is after 16 weeks of gestation. The purpose of the test is you have to obtain a fetal skin cells from the amniotic fluids for karyotyping and genetic testing, and under guidance of ultrasound ensure correct needle placement, avoid placental and uterine vessels injury. The maternal risk, if there will be RH negative isomerations, require anti-D immunoglobulin. If RH negative, infection risk is less 1 in 1000. The fetal risk of miscarriage risk is 1%, that is lower than the CVS. That is chorionic villus is slightly higher, that is 1.4%. In amniocentesis is 1%. The rare complications are amniotic fluid leak and fetal trauma, needle punctures. In amniocentesis, informed written consent has to be taken. Injection progesterone has to be given before the procedure. So very important, progesterone support has to be given before the procedure, and ultrasound you have to done to localize the placental localizations, and you have to do a fetal heart rate documented. This is the prerequisite before going for amniocentesis. Informed written consent has to be there. Injection progesterone before the procedures. Ultrasound for placental localization and FSH documentation has to be there, and you have to give antibiotic prophylaxis for 24 hours because you are inserting needle into the amniotic cavity, and ultrasound in the next day for FSH documentation has to be there, and discharge on the next day can be planned. So chorionic villus sampling, the time period is 11 to 14 weeks of gestational age. The purpose of the test is collect the chorionic or placental cells for karyotyping and genetic testing. Approach, you can go for a trans-abdominal approach or trans-cervical approach. The trans-abdominal, if the placenta is in the upper uterus, then you go for a trans-abdominal approach, and trans-cervical, if accessible by the cervix, you can go for a trans-cervical. This also under ultrasound guided, determine the placental locations and uterine shape. Maternal risk is there, that is tightly clamping, spotting, chorioamnionitis feature can be found. Rupture of membrane can occurs. RH isomerization require anti-D immunoglobulin negative mothers. Fetal disease, miscarriage risk CVS transabdominal is 1.9%, transcervical risk is 5 to 5.2%. Advantage of transabdominal versus the advantage of transabdominal is lower risk of infection, vaginal bleeding, prefer if contraindicated to transcervicals. The disadvantage of transabdominal is it will get more discomfort, less tissue for culture, difficult if placenta is posterior. So very important statement. So chorionic villus sampling, the technique of transabdominal chorionic villus sampling is the needle is guided from the patient's abdomen into the placenta. If placenta is anterior, very easy to go for a transabdominal under ultrasound guidance. And this is your chorionic villus. This has been done under transcervical route. The technique of transcervical chorionic villus sampling, a very thin forceps. You can see very thin forceps pass through the vagina into the placenta under the ultrasound guidance, and tissue has been retrieved. The cordocentessis fetal blood sampling, also known as percutaneous umbilical blood sampling (PUBS), is a procedure used to obtain fetal blood. Very important. The tissue has been skin cells, amniocentesis, and near the placental tissue. Now used fetal blood from the umbilical body is the fetal blood sampling, that is cordocentessis. The primary indication of the cordocentessis or fetal blood sampling is assess and treat fetal anemia due to alloimmunations. Basically, in case of fetal anemia or isoimmunations, that cases you do these things. Okay. So fetal transfusion, other use can be used for fetal transfusion, red blood cell transfusion, diagnostic treatment of platelet alloimmunations. In that case, you can go for this test. Okay, and rest is your fetal karyotyping, especially when mosaicism is suspected after amniocentesis or CVS. You can go for this cordocentessis fetal blood sampling. Decline use, improve amniocentesis technique have largely reduced the need for this procedure because amniocentesis has a good technique. So this procedure is largely reduced. The technique is needle insertion, a 20 to 23 gauge finally inserted in the umbilical vein, very important, not artery. Blood withdrawals, blood slowly withdrawn into heparinase series. Needle visualization, precise needle visualization is crucial. Longer needle may be needed for obese persons. Sampling site from near the placental cord insertion has to be taken or from a free loop, very important, free loop of the cords. Anesthesia, cord free loop. Local anesthesia may be inpatient to long procedure time, infection prevention sometime prophylactic antibiotic, avoided arterial puncture, avoided vasospasm, fetal bloody. Post procedure fetal cardiac functions motion has to be detected and the sign of blood bleeding has to be checked. So technique already I showed, ultrasound transducer, fetal blood sampling, access to the umbilical vein varies depending on the placental location, cord position with an anterior placenta. The needle may traverse the placenta, insert the posterior placentation with placental needle pass through the amniotic fluid before finding the umbilical vein. Alternatively, a free loop of cord may be accessed. Sonogram show anterior placenta with transplacental needle passes. This is in a placenta, through placenta needle is passing. So complications, fetal loss 1%, derivation in the procedure, cord vessels bleeding is 20 to 30%, fetal maternal bleeding is 40%, fetal bradycardia is 5 to 10%, success rate similar for placental cord insertion was the free loop sampling. Procedure time is 5 minutes to 7 minutes. Cord insertion time, pre-loop, okay, faster insertion site but high risk of complications. So now the diagnostic test